Genetic testing is increasingly playing an important role in clinical care, and the burden of responsibly ordering, interpreting, and acting on genetic information is increasingly likely to fall on generalist practitioners. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Stephanie Fullerton, a professor in the Department of Bioethics and Humanities at the University of Washington School of Medicine. Dr. Fullerton has co-authored a perspective article about the ethical challenges associated with clinical genetic testing as part of the journal series on the fundamentals of medical ethics. Dr. Fullerton, how is genetic testing currently being used in various specialties, and how do the results of those tests affect medical decision making?
Genetic testing is being used in a wide range of specialties currently, in particular in oncology, in neurology, endocrinology. And the ways in which genetic tests are typically being used is to give clinicians information about either particular treatments that a patient might benefit from as a consequence of the particular molecular profile of their disease, or to also give information about the potential for developing future health states. In certain cases, genetic information in the pediatric period can also be used to help diagnose hard to diagnose children. So there's a wide range of uses of genetic information in current clinical practice.
And then, what types of tests are under development and are likely to become part of standard medical care in years to come?
Well, the kinds of tests that I and my co-author, Kyle Brothers, focused on are tests that now increasingly are considering patterns of genetic variation across the entire genome, so-called whole genome sequencing tests, or also tests that involve going in and looking at particular places in the genome, polygenic variation or polygenic risk scores. And these are newer forms of testing, which were not previously possible, but now technically have become much more widespread and give a great deal of information, both about the particular question that a clinician might have about, for example, what kind of therapy to propose, but also can give additional unanticipated information about perhaps future genetic predispositions, future disease risks.
And then, how will primary care providers be involved in decisions related to genetic testing, and what will they need to know about these various available tests and their possible results?
So this is such a great question, and it's what we spend most of the time in this perspectives piece focusing on. In general, primary care clinicians have not been responsible for ordering genetic tests. They generally have wanted to refer patients to a genetic specialist, a medical geneticist. However, increasingly, there's two primary scenarios that we highlight. The first is a patient might actually come to the primary care provider saying, "Hey, I read about this test and I think it would be beneficial to me. Can you help me get it ordered?" And so basically patient-driven requests. But then increasingly, primary care clinicians, even if they are not the ones that have ordered the genetic test in the first place, may end up being responsible for managing follow-up care for a patient who has undergone one of these more expansive forms of genomic testing. And in terms of what kinds of information a primary care provider might wish to give their patients, there's a number of different issues that might need to be raised, both the kinds of findings that might result from a particular genetic test that might be ordered, the degree of certainty surrounding the information that might be provided, the likelihood that additional diagnostic testing and or other kinds of clinical care will follow a positive test result, and also discussing implications for biological family members who might share a similar genetic risk or genetic predisposition.
You say in your perspective article that although regulatory approval and insurance authorization generally signal that a test is reliable and has demonstrated clinical utility, other potential sequelae should be addressed to ensure informed decision making. So, what are some examples of those potential sequelae and how do you weigh them?
There's a number of different sequelae. Certainly the implications for family members, and in particular, so thinking about that, mainly it's not a reason why you would cause a patient to be hesitant about such testing, for example, but you just want patients to be aware that information that they find out about themselves could have implications for family members and to bear that in mind. We spend a little bit of time in our perspective article also talking about concerns with regard to genetic discrimination There is legislation that protects individuals against discrimination on the basis of employment or health insurance, but not all forms of genetic information are protected. And so people need to be aware that a genetic test result will be placed in their electronic health records and that could be available to others. And so they have to be comfortable with that. That's an additional sequelae. And then there's this far more difficult to grapple with concern, which is that the tests are coming out so quickly and our evidence base is still relatively limited, so that some genetic tests are not as able to discern risks to the same degree for all populations. And this dependence on the underlying database and the fact that the research is still proceeding apace insert some new complications, which mean that clinicians have to be sort of aware about possible test limitations and be ready to discuss those limitations with their patients as they're helping their patients decide whether to undergo testing or helping their patients to interpret particular test results.
So I think that you're alluding to this matter, but to ask directly, what particular ethical challenges are associated with genetic testing of patients from marginalized racial and ethnic groups?
There's a number of concerns. The first off is that many patients from marginalized backgrounds may not have access to kind of leading edge academic medical centers and have some barriers to healthcare access in the base case. But in the context of genetic testing, our ability to actually say things about the clinical meaning or clinical import of particular genetic changes that are identified in the genome are predicated on our ability to compare the patient's genetic sequence to other genetic sequences in databases that exist. And in fact, currently, we do not have as representative and diverse genetic databases as we would hope. So to the degree that patients from marginalized backgrounds may have less well-represented genetic ancestry, they may be more inclined to get uncertain results or to have greater uncertainty confidence intervals surrounding some kind of an aggregate estimate, such as a polygenic risk score.
And how could potential disparities of that sort be mitigated?
There's a number of approaches that could be taken. Obviously, the most important is to greatly diversify our research data, and we're making good progress on that count. But in the interim, in the meantime, taking great care when working with patients to understand possible test-related limitations, and so being very transparent and open about those limitations, working with healthcare institutions to ensure that the tests that are routinely ordered and offered to patients in the context of clinical care are those for which there is the most representative and kind of well-supported background data are a couple of steps that could be taken for sure. We need to be getting our research headed in the right direction. Unfortunately, we are beginning to do so.
And then finally, more broadly, and you've just begun to answer this question, what steps should healthcare institutions and clinicians take to ensure that genetic testing is incorporated into care in a way that's appropriate and that benefits patients?
Well, there's a number of steps that healthcare institutions can take. First, there is, and I neglected to mention this earlier, but we really are in the middle of a sort of a genetics specialist healthcare services kind of deficit. We don't have enough well-trained medical geneticists, which is part of the reason some of these burdens are falling to primary care physicians. So health systems, healthcare institutions working to create the right tools for generalist clinicians, bringing in specialist geneticists to help create tailored educational materials, for example, working to ensure that there's peer-to-peer support so that clinicians who would like additional information or support from a medical geneticist can access it instead of having to wait weeks for their patients to have a referral, for example, another important step that could be taken. We spent a little bit of time in our perspective talking about the fact that many results of genetic tests currently come in the form of a non-machine readable PDF. And so we need to be doing more to get genetic test results machine readable in electronic health records so generalists and other specialist clinicians don't overlook a relevant genetic test finding that might be in the patient's record just because it's not readily accessible. And then, of course, continuing attention to educational materials and in particular sort of equity-oriented materials to make sure that any patient that can benefit from genetic testing is given access to such testing, but that they also can understand well limitations that might be associated with those tests in the current moment.
Thank you, Dr. Fullerton.